Welcome to PharmaDocs with your host, myself, Dr. Jay Resnick, and Dr. John Robertson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Hey there, John. How you doing?
Jay, great. How about yourself out there
Very
on the
well,
West
very
Coast?
well. Yeah, very well.
The skiing machine right there, I should call you. The skiing PharmaDoc.
Yeah, I hung up the skis. I put them out in the garage for the winter, but I did get in 23 days of skiing, so I'm not going to complain about that.
And I got in 0 days. Okay.
Oh.
All right. And
All right, well, next year.
I'm dreading that. All right, because we love to go. It just worked out to be one of those years we just couldn't get it in the schedule.
Yeah, I've had a few years like that in the last 4 or 5 years, so I made up for it this year.
Yeah, and so since we last talked, Jay, the FDA has done it again. We'll get to these in a minute, but a remarkable another 12 drugs approved in 1 month.
Wow. It's a busy month.
Yeah.
1 month. Yeah.
So, I always like to go back and use that example you did when we first started PharmaDocs. If we have 12 and there's 12 months, that's 144 new drugs in 1 year.
Yeah.
So if you've been out 10 years and that trend is current, over 1,400 drug approvals you need to know about.
Yeah. Yeah. Because most of them will have some impact on your oral surgery practice or your dental practice.
Or general dentist.
Yeah.
Because if you're doing any type of invasive procedure, you need to be concerned about drug interactions.
Yeah, exactly. Drug interactions is the
post-op
medication they're on. Is it going to
adverse
affect
events.
healing? Is it going to affect bleeding? Increase their risk of infection? Yeah, all those are things we need to know.
Right.
All right. Well,
yeah. Let's get on it because
let's go.
We got that and some a new medical emergency to go over as well too.
Let me bring in our slides here.
Yes.
There we go.
All right.
All right. So today is May 10th already. Can you believe that?
Shocking, isn't
it? Goes by really quickly.
That's right. And it goes by. Yeah. It seems like I just turn around and I just did a PharmaDoc show with you.
Mm-hmm. Yeah.
And
it was a month ago.
Yeah, it was a month ago. Mm-hmm. But it's just exciting to see what all is being released on a monthly basis.
I think I was in Snowbird, right, when we did it?
Yes.
Yeah.
There he is, audience.
Yeah, now here I am back in LA.
Get in. I just say he got to go snow skiing.
Back to Encino, California. Okay, so
let's thank our sponsors. Got to have them. They're so kind to us.
Mm-hmm. Absolutely. So iCore Connect, which has their product iCore RX, which lets you e-prescribe from any device, your computer at the office, your computer at home, and even your smartphone. And then we've got Fortune Law Firm.
Aren't you going to lecture with some of them coming up?
Yeah, actually, the last couple ones I've done.
Okay.
Yeah. We've been working with Josh and those guys. Yeah, they're basically, they're not your typical law firm. What they do is they specialize in protecting what we have as clinicians and keeping us from harm and protecting our assets. So they have all kinds of different products. They have tax lawyers who know what the deductions are that we should be taking, that our accountant only deducts if we tell them about it. They've got ways to protect your assets, ways to protect your practice. And they say they want to be the first person to call if you have a malpractice claim before you even call your insurance company.
Yeah.
So they're really good guys, really smart.
That's a significant statement right there. So if you have an adverse event in your office, before you call the malpractice carrier, call these guys.
Yeah.
Aren't they also, Jay, they like to tout, they want to keep you out of the National Practitioners Data Bank too?
They sure do. Yeah. That's one of their goals.
And that's important.
Yeah.
Very important.
And then another sponsor is Vesper Institute, where we have our IV sedation course in Cincinnati, Ohio. And we've got a few dates coming up. I think the April was sold out. Yep. So I think we've got one coming up in June, and then a couple later in the year. And then, of course, in 2025. So if you want to learn IV sedation, come hang with us. We'll teach you everything you need to know to make you comfortable, and go back to your office and actually implement what we taught you.
That's correct.
And finally,
we got Balance Pharma, and they're going to make dental injections less painful and faster acting. So guess what? That's even better for our patients. And I strongly recommend everyone go to www.balancepharma.com.
Yeah, John, how does that work?
What's that?
How do they make the injection less painful and faster acting?
Well, the great thing about it, they've got this proprietary use of a sodium bicarbonate disc inside the cartridge, Jay, that when you activate the plunger, the disc goes into the local and diffuses and dissolves into it.
Yeah, so you don't have to draw up the bicarb yourself and inject using a 5 cc syringe. This will all work with your regular dental syringe that you have many of. All right, so let's get going on our drugs of the month. We're not going to talk about all of them because there are so many of them, as John said, 12. And the first drug that we're going to cover for May is Zevtera, which is ceftobiprole metoprolol. And John, tell us about that a little bit.
Well, Jay, as we can all see right there, it's for the treatment of bacteremia, skin and structure infections, as well as community-acquired bacterial pneumonia.
Yeah.
And, we're all concerned as dentists, and we'll get into this in just a minute, Jay, but, a transient bacteremia occurs within about the first 15 minutes of us doing a procedure.
Mm-hmm.
And why is that an issue? Well, what if that patient needs to be pre-medicated because of a possible artificial heart valve?
Mm-hmm.
Okay. And
these are high-risk patients, not
these
your
are high-risk
typical,
patients.
I have a murmur. Yeah.
And that's right. So what happens if you got a busy day in the office and everybody's running around? We've all been there. You go in, start a procedure, and you didn't check to see if someone took their pre-op antibiotics, but you do the procedure. All right. Then you get a phone call later on that evening. Hey, I've got some shortness of breath. I don't feel good. What's going on with that patient right there? Could they have an acute bacterial endocarditis starting right there? And that's something we got to be concerned about, Jay.
Yeah. So if that happens, this is what, a 4th or 5th generation cephalosporin.
Yes.
So it's not going to be your first line drug, but it's been found to be very effective against Staph aureus and also skin infections and skin structure infections, as well as endocarditis, infective endocarditis, if it's on the right side of the heart. So the other big indication for it, probably the most common indication, is going to be for community-acquired pneumonia. And there are lots of different buggers that can give you a community-acquired pneumonia. Probably the most common, they're mostly gram-positive bacteria like Staph aureus or some gram-negatives. And also, of course, we always have to worry about methicillin-resistant Staph aureus. So this is you can see here that there are a lot of different ways the pneumonia can develop. It can be viral, it can be bacterial, and then some patients are at higher risk because of their age, smoking, pulmonary disease, and then also, if they MRSA, they have increased risk to get that if they're in the ICU, if they're in the hospital, or if they've had influenza, or if their nasal cavities get colonized. So it can really increase the duration of a short hospital stay, let's say for an appendix.
Yes. Instead
of being in the hospital for overnight, they end up being in there for a week or two when they develop a pneumonia. And clinically,
CABP, as we like to use that acronym.
Yeah, we like acronyms. And some of the clinical signs you're going to see are fever, shivering, malaise, not feeling well, cough that may contain some sputum, green or yellow, which would indicate bacterial. They may develop a rash. They may get shorter breath or develop also diarrhea, depending on what bacteria. In fact, the rash you see most commonly if it's a mycoplasma pneumonia, which is that's what they call walking pneumonia.
That's right.
Yeah.
Walking pneumonia. That's
I had that in med school.
Oh, did you really?
Yeah. I was working. I was on, I think, on general surgery or ER, doing the night shifts as a third or fourth year medical student, and I was moonlighting doing oral surgery, and so I was going 24 hours a day. And finally, it just got to the point where I was just having a lot of shorter breath, and I went in, and sure enough, I had mycoplasma pneumonia. They put me on some erythromycin, and it was better in 2 days.
Awesome.
But so that's my walking pneumonia story. So the typical community-acquired pneumonia is usually acquired either outside the hospital. That's why they call it community-acquired, or within 48 hours of their hospital admission. And the most common cause of community-acquired pneumonia is Streptococcus pneumoniae is the most common. And again, the symptoms we just talked about: fever, cough, sputum, rigors, pleuritic chest pain. So it's like tightening in the chest, dyspnea, difficulty breathing, tachycardia, fast heart rate. And also what's very characteristic with pneumonias is you get consolidation because of fluid in the lungs.
Right.
And there are a number of oscillatory signs that you can use to check to see if there are areas in the lung that are consolidated. Of course, you're going to verify this on chest X-ray. You'll see infiltrates, but it's one of them is called agophony, and this is kind of cool in a way. You listen to the back, the lungs from the back, and you ask the patient, and it's usually the infiltrates are at the base, not higher up in the lungs. Yeah. You ask him to say E, and instead of hearing E, you hear A. So it actually changes the quality of the sound. And then there's, of course, whispered pectoriloquy, which is a phenomenon where you ask the patient to whisper very softly, and you can hear them through your stethoscope, through their lungs, because the lungs are dense and full of fluid. Normally, if someone whispers, you're not going to hear it through your stethoscope because the lung is full of air. And then finally, tactile fremitus, which is basically you'll feel vibrations of the chest when the patient is talking. Usually we tell the patient to say 99, 99, 99, 99. And so you're gonna feel the vibrations in your stethoscope, as well as hear it through your stethoscope also. So those are some fun facts about community-acquired pneumonia.
Now, Jay, to just go a little further, when we use the acronym, SAB, we're referring to Staphylococcus aureus bacteremia.
Right. SAB.
Yep. SAB. Mm-hmm. And, that is a concern for all of us that are practicing out there, because there's quite a few adverse reactions associated with SAB, and nausea, vomiting, hepatic enzyme and bilirubin increased, diarrhea, increased blood creatinine, hypertension, leukopenia, pyrexia. Now, that's just with SAB. Then there's ABSSSI, the acute bacterial skin and skin structure infections. And they're pretty much all the same, but it also includes rash along with dysgeusia as well, too.
Mm-hmm. Which is everything tastes bad.
Everything tastes bad.
Yeah.
It's like COVID, right?
Yeah,
so,
exactly.
And then finally, CABP, which is what we're talking about right there in that slide, community-acquired bacterial pneumonia. Mm-hmm. And pretty much all the same things, except you're going to have here abdominal pain, phlebitis, insomnia, and dizziness. Mm-hmm. So that this is a great medication to have right here. And
Yeah. And like I said, this is I think 4th or 5th generation cephalosporin that
Yes.
works the way other penicillins work, which is inhibiting bacterial cell wall synthesis, which kills them. And it's pretty rapid activity. It's generally given as an infusion over a period of about 2 hours,
Correct.
which I believe is just a single dose.
Yeah, that's
Yeah.
it. Yeah.
All right. And then just the common adverse effects are kind of what you would expect with most drugs: anemia, nausea, hypokalemia, vomiting, all the things that you just talked about.
Yeah.
So nothing out of as far as adverse reactions. It's kind of the same grouping of adverse reactions you see with a lot of different medications.
So if you wind up with a patient with the ABE, there's a very good chance Zevtera is going to be used on them.
Yeah. Yeah. Although I would think that they would try something else first.
Yeah,
Like cefotetan or something like that.
Yeah.
Ceftriaxone, one of the older 2nd and 3rd generation cephalosporins. All right,
course,
so
like they're worried about MRSA as well too. So
yeah. Well, I think in that case they would most definitely use the Zevtera. Anyway,
what's
so
our next drug? What a
our
cool
next
name.
drug is Xromi,
Xromi,
which is hydroxyurea, which is nothing new. Hydroxyurea has been around for over 100 years. It was actually first compounded in 1869.
Come on.
No, 1869 by Dressler
Wow.
and Stein in a series of experiments attempting to extract derivatives of urea. A century later, it was introduced as a clinical agent primarily as chemotherapy to treat various solid tumors and leukemias. And due to its early efficacy as a neoplastic agent, it was first approved by the USDA or US FDA in 1967 for treating CML, chronic myelogenous leukemia, psoriasis, melanoma, ovarian cancer, polycythemia vera, and even HIV. And in 1998, they approved the use of hydroxyurea for patients who have sickle cell anemia or sickle cell cell anemia.
Yeah, that's right. Sickle cell anemia. Yep.
Yeah. And so, like I said, it's really nothing new. But we should all know about sickle cell disease. We learned all about it in dental school. And of course,
and we've had quite a few drugs lately too, as well, Jay. In the last
we have, and it's due to a mutation in a hemoglobin gene known as hemoglobin S, and what that does is in areas of possible low oxygen tension, low O2 transport, it causes the cells to sickle, and you get this instead of the round red blood cells like we're used to, they're these sickle-shaped cells. And they're stiff, and what they do is they basically block small blood vessels.
And they can't transport O2 effectively at all.
Exactly, and so these end organs, the extremities in the abdomen, patients will feel weak. They may have abdominal pain. They could end up with renal damage. Liver damage, and even paralysis if it's really bad. And it affects 1 out of 400 African Americans. So it's not an uncommon disease. And so this is a great new drug to treat it. I think it's a different formulation of hydroxyurea. Let's see. It's a solution that is used once a day. Orally once a day.
And Jay, whenever we treat these patients in our office, you got to ask yourself, if you do something like an extraction on these patients, you could put them in a sickle cell crisis.
Yeah.
And because it's very important to keep them well hydrated and well oxygenated when you're doing a procedure. So this is where you might want to utilize a referral to your specialist, because they're definitely on a bag of IV fluids and oxygen to try to prevent them going into crisis, because they're going to be miserable. They're going to be hurting.
Yeah.
All right.
And I would surmise from the fact that it's a daily oral solution that this is also used for prevention.
Yes.
Of sickle cell anemia and sickle cell disease. All right.
So that's a great point to bring up too, Jay. So everybody needs to remember this next time you have a patient in to find out if they're on Xromi.
Yeah. Or any hydroxyurea. Yeah.
Yeah. Or they may want to get started on that before they do a procedure. Anything we can do to keep them from going into sickle cell crisis is a blessing. Okay.
Yep. That's how we want to operate. All right. So the next drug is Rezenopy, which is a drug that we're very familiar with, naloxone, which of course is an opioid antagonist used for treating suspected opioid overdose, where the patient has respiratory depression, CNS depression, both in adult and in pediatric patients.
You know, Jay, I want to make a point. Since we started PharmaDocs, do you know that we've had all of the newer versions of naloxone on our show?
Yeah.
I mean, they've all come out.
Even naloxone nasal spray.
Yes.
Has come out during PharmaDocs.
Yes.
Yeah.
And so this ought to tell everybody the opioid crisis is still here, and it's here to stay.
Yeah. In fact, it's getting worse. They say we're in the fourth wave of the opioid crisis right now, due to mixing opioids with other things like benzodiazepines, xylazine, other medications, polypharmacy, in addition to the opioids. It's making the symptoms of overdose a lot worse and has a higher mortality rate. So this is another.
Jay, I was going to say, and the emergency drug kit companies are now starting to put Narcan nasal spray in their kits as well too.
Yeah.
And so you're going to eventually see one of these patients in your office.
Yeah, it's a handy way if you don't have an IV in, or it takes time to draw up some IM naloxone, to just have that handy. In case you need to reverse an opioid, or if you're out and about. Yeah. It wouldn't be such a bad idea to have one or two of these in your car, just in case you come across someone who is a suspected opioid overdose, who's overdosed, and you could save a life.
But when you open the package, do not prime it.
Yeah.
It's ready to go.
Right. Yeah. It's not like your typical nasal spray where you have to prime it a couple times. It's ready to go. If you get one spray and that's it.
That's it.
Yeah. So some of the others are, this is a high dose formulation containing 10 milligrams. 10, count them, 10 of naloxone. And there's some others like Cloxato, that's an 8 milligram spray. Right. Narcan is 4. And then there's another one called Revive. And Rextovy, which is 4, and then Revive, which is actually only 3. It's actually manufactured and sold by a nonprofit pharmaceutical company, which is pretty interesting.
And Revive is over the counter. You can buy that, like you said. We are healthcare professionals. We can save a life. Yeah. And you might be somewhere where someone's overdosing it. Yeah. And hey, drugs do not discriminate.
Yeah. And many times you have to give the patient a second spray. So you give them the initial 4 of naloxone, and then you have to give them another 4, maybe 5 minutes later. So you would think that giving them 10 at the beginning would be a good thing, right?
It should be.
Yeah. Well,
but you can't give no more than 2 sprays of Rezenopy in one day.
Yeah, because it's so high dose. So I came across an article in Morbidity and Mortality Weekly Report, February 8th of this year. And this involves Cloxato, which is an 8 milligram intranasal naloxone spray. And so they provided this to New York State Department of Health and New York State police troops with both the 8 milligram intranasal naloxone and the 4. And basically what they found was there was no significant difference in survival, mean number of doses administered, prevalence of post naloxone signs and symptoms, post-naloxone anger or combativeness, or hospital transport refusal, whether they were given 4 or 8. The only difference was those who received the 8 milligram dose had 2.5 times the risk for opioid withdrawal signs, like vomiting and
hey, that's brutal. That's brutal. On
so that's really interesting.
Yeah.
So that that may inhibit the popularity of these high dose if it it doesn't work any better, and it has a higher risk of the patient developing going into withdrawal.
Well, Jay, as far as talking about the time difference between doses, some people with these sprays want to give it and then they don't do anything. They're still unresponsive.
Mm-hmm.
They want to give it again. You've got to wait about 2 minutes before, at least 2 minutes, before you give that next dose, because the problem is when you start pumping them full of all of this naloxone, like you just said, they're going to wind up with opioid withdrawal syndrome, OWS, and these patients literally want to die.
Yeah.
And they're in so much
very
pain.
uncomfortable. Yeah.
Very uncomfortable.
Yeah.
Yes.
I mean, there are ways to medically manage them and get them through it. And luckily, withdrawal is not life-threatening. But
and something else,
it's
Jay,
very uncomfortable. Yeah.
When we're giving these injections, we got to remember also, not only are we administering a medication, but we got to maintain their airway.
Right.
Because they're probably still going to be unresponsive.
Yeah, they're going to be obtunded. Yeah, they're going to be unresponsive. Their tongue's going to fall back. Their jaw's going to fall back.
You have to do a jaw thrust. Okay.
Yeah, you have to maintain their airway. So I think it was a few months ago, I talked about an article I read from an ER doc, ER or I think or addiction. I can't remember. And basically, the title of the article was. If 2 doses of naloxone don't work, should I give a third?
No.
And
you
so
need to start thinking of something else.
Exactly. You got to start thinking of something else. And now that we're in that 4th wave of the opioid crisis, you got to think about benzodiazepines. You got to think about xylazine. Benzos obviously have a reversal agent, romazicon. Xylazines don't. There's no reversal agent for xylazine. You just have to. The patient has to be stabilized, and or barbiturates, or cocaine.
On xylazine, they're actually working on. Remember now, this drug is mostly used by veterinarians. Okay.
Yeah.
They're working on a reversal agent for animals for this right now.
Yeah. I mean that's where it came from.
Yes.
The brand name is Rompum, and I actually, when I was in dental school. Long time ago, when we were doing surgery on bunny rabbits, that's what we used to put them to sleep was the xylazine, and they stay asleep for a while. It lasts, and if you have that on top of an opioid, and the reason that addicts will use xylazine in addition to an opioid is it prolongs the action, it prolongs the high, but sometimes it's too much of a good thing, and they can really get into trouble with that. Okay, our next drug is Pivya, which is pivmethicillin, pivmethicillinam, which
I thought you were about to say Piv, Mississippi.
1 Mississippi, 2 Mississippi, which of course you can kind of guess from the name that this is a penicillin class antibacterial that's used in the treatment of
UTIs.
Uncomplicated urinary tract infections.
Now, last month we talked about another one that was complicated. All right.
Mm-hmm. Yeah. So this is uncomplicated UTIs, but it's indicated for the treatment of female patients 18 years of age and over, who have infections caused by E. coli, Proteus mirabilis, and Staphylococcus saprophyticus. So it's not, I guess, indicated for men with uncomplicated UTI, just women.
Yeah.
And so they don't recommend that if you strongly suspect a bacterial UTI, or you have evidence, say from a blood culture or urine culture, then it's okay to give because this is a very specific penicillin drug that, if you use it indiscriminately, will increase the likelihood of resistant bacteria developing.
Yeah, it's
So
almost
only,
like targeted therapy, Jay.
exactly. So only if it's proven or strongly suspected to be bacterial do they recommend using this drug. Oh, okay. So just to kind of talk about the difference between uncomplicated and complicated, John.
Yeah. Well, the infection is found in a person in a normal urinary tract. And so it can be associated with any type of underlying condition. So you can see that on the left of our slide right there, Jay, whether it be pyelonephritis or a ureter infection or a cystitis or urethritis or prostatitis in a male. So more than likely, these are the ones that we're going to see with this type of UTI that is caused by a bacteria.
Yeah, and the typical signs are, this urea burning while urinating, and frequency and urgency to urinate. Another common sign. Most of these just go away by themselves after a day or two. You just have a little cranberry juice and to acidify the urine, and it goes away in a day or so. But the complicated is when there's an underlying condition, another medical condition that is complicating this uncomplicated urinary tract infection. All right, so here we're on to our next drug, and this is Libervant, which is a formulation of diazepam, which we all know has been around for a long time.
Yes.
Trade name is, of course, Valium, and we used to use that. We sometimes give that to patients for PO sedation, or we may use it IV for sedation. We used to use it. We don't really use it so much anymore. We use midazolam. Yeah. But this is given to basically children between age 2 to 5 that have a seizure disorder. So if they have a seizure, the parent or whoever's with the kid takes one of these films of benzodiazepine, and it's basically usually they come in 5, 7.5, 10, 12.5, and 15 milligram strengths. And of course, you're gonna start low until you know how the kid's going to react. But this is used when these patients have seizure clusters, which means they're repetitive, they're acute repetitive. It's different than their usual pattern. They're getting more common and more difficult to eradicate. And I was looking up on the website of the manufacturer of this, Acquisitive Therapeutics, to just see what they said about it. Actually, I was looking for the dosing, and I found something very interesting under important safety information. Remember, this is for 3 to 5-year-olds. Do not allow your child to drive a motor vehicle, operate heavy machinery, or ride a bicycle until you know how it's going to affect them. I mean, how many kids between 3 and 5 operate heavy machinery or drive?
Well, they might have one of those large Tonka toys that are battery operated.
Yeah, maybe in Mississippi.
Yeah.
But I thought that was kind of humorous in our, sick medical humor kind of way.
That's right.
But this is instead, because intravenous or IM Valium diazepam is not readily available, this film will, right now it's indicated for the 2 to 5 age group, and it probably will be for older patients up to 18, and of course then probably over 18 at some point. I would.
Jay, I couldn't find it. Does it have a pill pack or a pill backing that you peel off and then you place it on?
No, I think have you ever used those Listerment films?
Yes.
Yeah, I think it's just like that. You just peel it out, and I don't know what the packaging looks like, but I guess it just comes out. You stick it to the buccal mucosa, and it gets rapidly absorbed. So that's kind of interesting. New way of delivering drugs rapidly.
Right. So I'm just trying to imagine, because this will eventually be approved for adults as well too. So you've got a patient in your chair having a full-blown seizure right there. And we always talk about trying to protect them as well too. Do you feel comfortable trying to get that buccal film inside their mouth?
Not while they're going through a seizure, but probably, yeah. And of course we have IM and IV in our offices.
That's
but certainly in this 2 to 5 age group, they're an airway in this age group is not a small adult airway. It's a totally different airway.
Correct.
And so you've got to try to break the seizure. And of course, the kid's going to have all primary teeth. So if you can just kind of pull their buccal mucosa and stick it in there, this will go a long way to hopefully either reduce the seizure activity or eliminate it until you can get them to further treatment.
And I just want to stress, this is a benzodiazepine. So if you happen to have this in the office and you use it, you've got to get some oxygen on this child. And you've got to ventilate. You've got to make sure you're breathing for this.
Yeah, you got to make sure that you have an open airway.
Correct, because they will become attended due to this medication right here.
Exactly. All right. So seizures we have generalized seizures and focal seizures.
Yep.
And generalized seizure affects basically all of the brain, whereas a focal seizure is only certain areas of the brain. So maybe a temporal lobe seizure, for example, where the patient may be fully conscious and aware of what's going on, whereas with a generalized seizure, they usually lose consciousness and continence. Yeah, actually both.
Yeah, that's true.
All right. So the definition of seizure clusters remains unclear. It's also called acute repetitive seizures or serial, recurrent, or crescendo seizures. And as you can see here, there are a number of risk factors. Temporal lobe epilepsy, symptomatic with a history of head trauma, drug-resistant epilepsy of long duration, and history of status epilepticus and other seizure-related hospitalizations, and of course non-compliance with seizure medications. Yep. So that's the circumstances where we may see these seizure clusters. All right. Our next drug here is Beqvez.
Yeah.
And otherwise known as the generic is fidanacogene. And so I'll let you pronounce the full name there.
Oh, how do you like that? The Elaparvec, DZKT.
Yeah.
All right.
All right.
I mean, it's amazing some of these generic names right there.
Yeah.
Wow.
Yeah. It's amazing that people can remember these.
Oh, I know it. And just think about it. I mean, you're using a virus now to treat severe hemophilia.
Yeah.
All right.
So it's a virus-based vector gene therapy.
Yeah.
It's injected into viruses that actually are injected into the patient, and it produces these clotting factors that they need. And so it's used for hemophilia B, which is a factor 9 deficiency.
So, and it's also used, Jay, for patients who are currently using factor 9 prophylaxis therapy, or have a current or historical life-threatening hemorrhage, or have repeated spontaneous bleeding episodes, and do not have neutralizing antibodies to adeno-associated virus serotypes.
Right. So if they're factor 9 deficient, this helps increase their factor 9 level using viruses as a vector. So viruses can be our friends sometimes.
So what? Okay. Bottom line, audience, why does this matter to us? You're going to have people in your office that have to have extractions, and they're going to be a hemophilia A or a hemophilia B.
Yeah.
And just like what I just read about life-threatening hemorrhage, this can be a significant amount of blood loss.
Yeah.
So,
and so
this
is something obviously,
when
you see in the medical history, you've got to ask them about bleeding episodes and how easily do you bleed and what % factor do you have.
And have you ever been hospitalized due to this as well, too?
Yeah. So hemophilia A.
Medical history, Jay. It's all about the medical history.
Yeah. So hemophilia A is a factor 12 deficiency, and that's 80% of hemophiliacs. And it's more common in men rather, as you can see, rather than women. And let's see, 400,000 people have it. Of them, only 160,000 have actually been diagnosed.
Yeah. Wow.
All right. So let's just go back for a second. So it's gene therapy that contains a bioengineered adenovirus capsid, which is the protein shell, and a high activity variant of human coagulation factor 9 gene. So they're injecting factor 9 gene into this adenovirus, which will then replicate the factor 9. And it's given IV over about a 60-minute period. All right. Anything else to add on
No, that's
Beqvez?
it right there. Yeah.
Okay. So that brings us to our medical emergency of the month.
So, Jay, this can happen anytime at any day in a dental office.
Or outside the dental office.
Or outside the dental office, correct. This patient may present like an aura or some type of blank stare, or their eyes appear to roll back. And then, of course, involuntary movements.
Yeah.
So take a guess.
Well, I mean,
Audience, what is
people might guess syncope, but that's not what it is.
No.
It's a seizure disorder.
Yeah.
That we just talked about.
That we just talked about. That's
epilepsy. Right. And again, epilepsy is the disorder where patient has multiple seizures. Patient can have a single seizure brought on by fever, trauma, medications, all kinds of things. And so the way that we handle this is, of course, we go to our checklist, our step-by-step. And remember, the first thing to always do is remain calm, because if you're anxious and excited, and you're not going to think very well. So you got to step back, calm down, and then take out your algorithm. Obviously, you're going to stop doing whatever you're doing with the patient, and take everything out of their mouth when you can, or as quickly as you can. And you want them supine with their legs above the heart, so it increases their venous return. And of course, you want to protect them from injury.
correct. And you and your staff want to get on each side of the chair if this happens in the operatory, to make sure that they don't hurt themselves and they sure don't fall out of your chair.
Even if you have armrests.
Yes.
You gotta protect them.
You got to protect them, because if they fall out of your chair, now you might have a head injury.
Yeah, exactly. And so you want to, make sure if you can, suction the oral cavity. Of course, you're going to go
with
on
the
the buccal.
Yankauer.
Yeah, Yankauer suction on the buccal, because you're not going to be able, if they're seizing, you're not going to be able to get past the teeth. Put them on monitors, give them oxygen. And if they rapidly gain consciousness, and this is something that happens to them all the time, at that point, discharge them, but talk to their physician and see if they have any recommendations for next time. But if they remain unconscious, then of course we have the other branch of the algorithm.
And hopefully you have already called 911 on this as well too. And that other portion of the algorithm is so important, because we've already talked about Libervant, which is Valium, and hopefully you have one or either or of these in your office: diazepam, which is Valium, or midazolam, which is Versed. And if you're able,
you can give intramuscularly.
That's right. You can give it IM. If you don't have the ability to start an IV, you can give it IM, and you see the doses right there as well too. And then once you give it, like I said, you've got to be able to maintain an airway, because hopefully this medication will break the seizure, because when EMS gets there, this is the antidote to a seizure. That's exactly what EMS is going to give these patients.
Yeah, exactly. So if you can do it before they get there,
yes,
and then just rescue breathe for the patient, they're going to have a better outcome than if the seizure is prolonged because you didn't do anything.
Right. And when Jay talks about rescue breathing, this is where hopefully you've got an ambu bag in your office. If you don't, I hope you order one after you watch our show, because you're going to have to get a good seal, and we like to call it the CE seal, because that's the way you hold your hand against the face mask against the person's face, so that when you ventilate, they are receiving air. It's not blowing outside of the mask.
You need a tight seal. And also, you may need to put in an oral airway, because if the tongue falls back and you give positive pressure, you may just push the tongue further back. So if the patient's unconscious, you'll place an oral airway. If the patient's semi-conscious, they don't like that very much. You're going to place a nasal airway.
Trumpet. That's right.
Yeah. Okay. All right. So I guess that we've covered everything. We just want to do our shameless promotions of some of the things that we've got online and available for you. PharmaDent through dentallearning.net, only $99, covers 24 categories of drugs. and tells you, kind of brings you up to date. So, and these are not the new drugs that are coming out. These are kind of the standard, tried and true medications that have been out for years that you need to know about in your dental practice.
And then there's our famous Dr. Resnick right there on DOMS. Dental Office Medical Emergency Simulation does a phenomenal job through these 5 modules, giving you an introduction to medical emergency preparation, followed by modules 1, 2, 3, and 4. And each one of those modules have 6 different medical emergencies.
Yeah.
And at $99, what a bargain.
Yeah.
You don't have to leave your office because, one thing we always hear is so many people saying, I can't find a lecture on medical emergencies.
Yeah.
Okay, stop worrying about it. Stop stressing it. It's right
We got
there.
you covered.
Yeah, you're covered.
2.5 hours of CE for only $99. And then again, to plug our IV sedation course in Cincinnati at Vesper Institute, I think we have probably the best IV sedation training around.
Absolutely.
Because we go about this from a different standpoint as practicing surgeons who are educators, as well as a general dentist who's IV sedation trained. And our goal is not to have you come and pay a lot of money and take a course and go back to your office and do nothing. We want you to be able to take the course because you want to bring IV sedation into your practice. And have the tools that you need and the confidence you need to go back and implement IV sedation in your practice as soon as you get home, or shortly
Jake,
thereafter.
Coming up next month, we're going to do a webinar on dental learning about focusing on patient safety. We want to make patient safety through IV sedation. Okay.
Yeah.
We want to make all of you feel very comfortable about this. I mean, if you're anxious, nervous, afraid, we are going to eliminate those for you.
Yeah. Because IV sedation, moderate sedation is fairly pretty safe. You just have to know what you're doing.
Yes.
And watch, don't overdose your patient.
I mean, come learn from 3 men that have over 150,000 cases underneath their belt.
Plus one-on-one with IV sedation trained general dentists as your one-on-one mentors.
Program right there, Jay.
Yeah.
I'm just telling you.
Okay.
And then, of course, there's one I just released not too long ago. On some of the webinars I've done, people said the same thing. I'm looking for a pediatric course. Well, I went ahead and developed that for you. And look at that. Pediatric medical sedation and airway emergencies, 3 hours right there. $29.
Yeah. I mean, that's what you'd spend at Starbucks in 3 hours, right?
Yeah.
All right. So our next episode of PharmaDocs is going to be next month. Remember the second Friday of the month, and that's going to be June 14th.
Yep.
And let's see, where I'm just kind of getting ready for us here. And so June 14th, we'll have drugs that were approved by the FDA during this month, the month of May, and of course a new medical emergency of the month. All right, John, any famous last words?
Well, I just want to thank everybody for spending time with us, and I just hope this is beneficial for you, just like it is for us, because I'm a professional student, and I know Jay is, and I hope all of you are as well, too, because we should all want to learn.
Absolutely. So we'll see you all
Absolutely. Bye-bye.
next month.